Today I will be talking about assessing municipal resource allocation and utilization for nutrition. I'm involved with the Suahara program, and just a note of thanks for all the team members involved in this study. So just the outline of my presentation, I'll be starting with the background of this the study methodology, the findings, and finally the implications for program as well as research. So we've Dr. Cunningham has already spoken about the background of Suahara, so I will only be speaking about Suahara and what it does in governance. So one of the intermediate results of Suahara program is to support the government in the accelerated rollout of the multi-sector nutrition plan. We do that by working with national, provincial, and municipal level governments. So basically what we do is we advocate and lobby for local investments in nutrition, as well as we provide technical support to the government for nutrition activities as and when needed. So the purpose of doing the study was that our internal data, Suahara internal data showed that out of 30 of our 42 Suahara districts, $8.4 had been allocated by the budget for integrated nutrition activities, which is great, but only 41% was being utilized. So we wanted to understand why. As part of the background, just to look at our government structure, the federal government, provincial, and municipality government. So in this presentation, we'll be focusing on the municipal government, who now has the authority to allocate and utilize the budget. So just a look at the local government structure. So there's municipal level council, executive, and the municipality is headed by chair and vice chair. So I'd just like to point out that everyone on the top, 4 boxes, they're mostly elected representatives. And from administrative officer onwards, if you look at the 6 sectoral units, they are mostly government staff. And we also have wards under the municipality. So study aims, what we wanted to do was understand how the municipalities were allocating budget to different activities and how they were utilizing it in general, and in particular, where did nutrition come into the picture? So our study sites included 4 districts, Atham, Dang, Sindhupalchok, and Nuwakot, and 7 municipalities within these districts. So the municipalities were selected based, again, on our internal data, based on high or low allocation or no allocation in nutrition. Our methodology, we used 4 different qualitative techniques, the first one being in-depth interviews. So we interviewed elected representatives as well as government staff from municipality as well as ward levels. At the community level, we conducted focus group discussions with people such as school principals, health workers, FCHVs, those who would likely be engaged in budget allocation and utilization process. Next, we observed any kind of budget allocation or utilization activities that happened during the data collection period. And we also reviewed documents related to budget allocation and utilization. So that's just a picture of the documents that we reviewed from one district. Data was collected from 1st to 27th May. All the interviews and discussions were transcribed in Nepali in the field and translated to English. For the documents, the study team reviewed the documents and summarized it in English. Coding and analysis was conducted in NVivo 12, and we used a thematic analysis approach. So moving on to the findings, I will just show you how the 7-step planning process, or how budget is allocated and where nutrition fits here. So steps 1 and 2, nutrition doesn't come much into the picture. It's basically how the municipality estimates its total budget. So internal budget of the taxes and the fees it charges, and external budget of what it's going to receive from the federal and the provincial governments. So after the budget ceiling is determined, the municipality spreads the budget, how much it is going to, how much each ward gets, and how much each sectoral unit, the 6 that I showed earlier, how much each sectoral unit is going to get. So it allocates budget, estimates an allocation of budget, and then shares it with different wards. So the ward receives a budget ceiling from the municipality. Then what the ward does, it goes to the communities, to the settlements, to the people, to understand what their needs are. So it is at this point that community people can bring in nutrition needs, asking for budget, but not just community people. Health Facility Operation Management Committee, mothers groups, FCHVs, they all can come forth with nutrition-related demands. So these demands are then submitted to the ward, which then the ward receives hundreds of demands. So it cannot. So it needs to select and prioritize. But also, if some plans, if some immediate or needed plans are missing, the wards can also put in plans. So therefore, nutrition plans can also come in through the ward. So the ward then lists prioritized plans and submits it to the municipality. So in the municipality, if you remember the 6 thematic committees, they are the ones who look at the plans from their own sectors. For example, nutrition plans would go to the health section. And also the health committees can also add nutrition-related plans if they feel if it is missing. After the thematic units look at the plans, prioritize, discard some, they forward it to the Municipal Executive Committee, which is basically a body of the local elected members. The Executive Committee then finalizes all the plans and forwards it to the Municipal Assembly. And the Municipal Assembly is sort of like a public hearing where there are public representatives, government staff, and anybody from the municipality can come. So it's a participatory process where budget is allocated. So in terms of nutrition, budget is allocated lump sum under health. So budget allocation areas, where are the budget allocated? Mostly infrastructure, road, irrigation, drinking water, but also some budget is allocated in nutrition. So these are the areas, like budget is allocated for iodine, for health mothers group meetings, as incentives, for plastic ponds, for agriculture activities related to nutrition, egg distribution, etc. There were more nutrition activities in Assam district compared to other districts, and we feel it's because of the multi-sector nutrition plan being implemented in Assam by government and UNICEF. So let's move on now to the allocation facilitators. So the general facilitators for budget allocation were a sense of responsibility among elected representatives, very good coordination with EDPs, increased community participation and awareness, and guidelines guidelines even existing at the municipality level. Specific facilitators to nutrition include the multi-sector nutrition plan and elected representatives sensitized in nutrition as well as willing to invest in nutrition. General barriers to allocation included a low community participation in some of our study sites, not enough budget ceiling, insufficient coordination with EDPs, again in some study sites, and insufficient experience because we're relatively new at all of this, that's why, and delay in planning process, and in some cases lack of staff, inactive staff, etc. Barriers specific to nutrition include priority to visible plans, like buildings and everything, and plans not proposed from the community levels. So health workers or even community people, they're not asking for nutrition-related plans. And perception by the elected leaders that enough is being done in nutrition by EDPs and by our national program, so we don't need to allocate anything more. So sort of that kind of perception. And also, even those who want to allocate budget to nutrition, they didn't really know how and where, because already there are existing programs, so what else can be done, they were not sure. So let's look quickly at the utilization process then. So after the budget is approved from the municipal assembly, the municipality chief hands over the official authority to the chief administrative officer. So the chief administrative officer collaborates with the wards and different thematic sections and comes up with an integrated plan for implementation, which again needs to be approved by the executive committee of the municipality. A monitoring and supervision committee is formed and a monitoring and supervision plan is formulated. Implementation modality is different for different kinds of plans, but for nutrition-related plans and for health-related plans, it's mostly via the health committee and implemented via the health facility or HFOMC. Payment. The payment process is done after the plan is completed, after all the bills are completed and public hearings are done. So let's look at the facilitators, utilization facilitators. So the utilization facilitators are very general, and they also apply to nutrition. Community participation, good coordination with EDPs again, training on budget utilization, availability of policy, acts and guidelines, good monitoring, joint monitoring with EDPs. So barriers related to utilization include insufficient or no coordination with EDPs in some cases. Again, no experience. This is a new experience for us. Tedious reimbursement process, lack of staff and technical skills, lack of community ownership, and insufficient estimation of budget in some line items, insufficient monitoring, delay at several points of implementation, and in some cases, political influence and opposition. So moving on to the strengths and limitations of the study, one of the biggest strengths of our study is that we've triangulated findings from 4 different methods, and our study sites have included all 3 agroecological zones of Nepal and also high and low allocation municipalities. And also, as is the strength of any qualitative study, our findings offer depth and breadth of the topic studied. Limitations, usually with the qualitative study, we go and validate the findings, but we could not do that in this case. And also, we only went to 7 out of the 389 municipalities where Suahara is working, and the 753 municipalities in total, so it's not representative. And our studies were conducted in Suahara 2 implementation areas only. So next steps, what can we do as what can programs and programs and implementers do? At the community level, I think awareness regarding nutrition to the general community, especially to FCHVs and HFOMCs, so that they can propose nutrition-related plans. And at the ward and municipality levels, we need to continue raising awareness on the importance of nutrition, but also collaboratively work with how to formulate nutrition-related plans. And also we need to target not just the elected representatives, but also the thematic committee members, so like health facility workers and health coordinators, health chiefs, etc., because they also play a key role in budget allocation and utilization. And as EDPs, we need to continue to provide technical support and improve coordination. And also promote local government ownership, because if we're looking at sustainability, government ownership is very important. Next steps for research, we recommend that similar studies also need to be conducted in non-Suahara areas, and maybe comparative studies between MSNP implemented and non-MSNP implemented districts. And also studies, probably studies linking municipality-specific nutrition needs. So what is the nutrition need of the municipality, and are they allocating budget and utilizing accordingly or not? And maybe mixed methods or quantitative surveys for more generalizable information. Thank you very much.